Good afternoon. My name is Leandra Weiss, and I am here on behalf of the Advocacy Committee. As you know, we are working on strategic goals, and one of them is to provide webinars for our members. And this is the first of a few of them. And I just want to remind you that the QR code will be at the end, or you can use that link to get to resources. We want to hold questions primarily until the end, or you can put them in the chat and I'll be monitoring that. Um, I have been a nurse for over 32 years. I started off at the bedside and I've chosen to work primarily in ambulatory care because I have found that this is where I can make a big difference as a nurse. I welcome you to our webinar, A Nurse's Call to Action, Advocating for Health Equity. And it is my great pleasure to introduce my wonderful colleague, Dr. Portia Zaire.
Thanks, Leandra. I appreciate you. Hi, everybody. My name is Portia Zaire, and I am excited to be here with you guys today to do this webinar about advocacy and health equity and a little bit about policy and things and whatnot. I have been a nurse for 18 years, and a big chunk of that has been in the ambulatory care space. And like Leandria, I think I like this space mostly because of the opportunity to care for the whole patient. But in real life, I love ambulatory care because it breathes and lends well to creativity of innovation. So being able to think outside the box and be critically thinking about how we can change and adjust and how we can adapt to our patients' needs, especially what's going on in the community. So I hope that you all can get something out of this webinar. Please be engaged. Please use the chat box. I'm super informal. So if you have something to say, please just put it in the chat. We'll get to it. We'll have a conversation. There's no need to wait until the end of the presentation to actually engage and to say the things that you want to say or to ask clarifying questions. We're super laid back and chill. So um, we would love to hear from you as we go through. And I do believe that this is being recorded. And Stephanie will have probably more information about how to get to that recording when we're done. So our disclosures, we don't really have a lot of disclosures. No one is paying us to do this. We're not backed by different corporations, and we're really representing ourselves as individual nurses, as many of you are. And even though I'm a postdoc at the University of Michigan, I'm not here as a representative of the University of Michigan or any other job or organization or association that I belong to. Is really as an individual nurse with my collective years of experience and expertise. So we hope that by the end of this presentation, you'll be able to examine the foundations of advocacy and explore ethical and professional obligations that shape nursing practice, engage with practical, standard, and innovative strategies to strengthen your advocacy efforts through a health equity lens, deepen your understanding of health equity and the implications for nursing and how we deliver care. Identify and discuss strategies for building structures that advance the nursing profession through a commitment to health equity. And then finally, we hope that you're able to get the resources that you need in order to be an advocate for health equity. And I'm just going to put my phone on Do Not Disturb. Okay. So I wanted to start off with a quick survey. I wanted to see how everybody is feeling right now. You registered for this presentation, and I want to know, what are your expectations? Like, how emotionally, how would you describe how you feel right now walking into this webinar? So you can go to the QR code, or you can go to slido.com and put in that code, and then just type in how you're feeling. I'll give you a few moments to do that, and then we'll share the results of that. And let me know if you have any problem getting to this app. feel like I need that Jeopardy music. Oh, we can see at the top how many people. Okay, yep. Overwhelmed, worried, excited, okay. People are feeling excited, pulled in many directions. Okay. Just back from Triple ACN, so you're all geeked up. I get it, empowered, anticipating, interested, content, okay. Excited to learn. So people are excited. Okay. Tired, worried, a bit fearful of the current. Yeah, yeah, a bit fearful. Yeah, I think a lot of people are. Mm-hmm. Stressed to the max, honey. That stress need to be in bigger letters. But excited has won over. Anxious, a bit okay about the current state of our nation. Yeah, all of the things. All of the things. Somebody's typing. I'm gonna okay, y'all come on. Yes, nervous, curious. Yes, all the things. Okay. Yeah. So I think this is appropriate for what we have going on here. I think we are all feeling the same way. So I wanted to take a moment and say this is a safe space. I am not trying to sway you in one way or the other. However, I would be remiss if I didn't tell you the lens in which I am presenting this information. So, I like to call myself a scholar activist, meaning that I use my knowledge, skills, ability, education and experience in order to be an activist for those things that I believe in. And genuinely, I'm always going to be on the side of the oppressed and not on the side of the oppressor. I have always lived in mixed income and in multiracial neighborhoods. So my lens is broad and diverse and wide open. So I can be empathetic to a lot of different points of views and challenges. I have a bleeding heart. So as I am presenting this information, I that is the lens and the background from where I'm coming. But at the same time, I'm a Libra, right? So I can always see the balance of things. Things are never just black and white for me. There's a lot of gray area. So I hope that we can engage in productive dialogue about where we're going. So that's the lens and where I see it. I hope that our worldviews allow us to have a good scholarly dialogue and help us to do the things that we need to do in order to move forward. Now, why as a group are we deciding, yes, this is the time to put on this health equity and advocacy webinar? And with everything that's going on, like, why are we conducting this now? Okay. We want to make sure that the nurses within our ranks have the proper knowledge, skills, and abilities to speak up for the communities that they serve. Okay. We also want you to be advocate for the profession and then for healthcare at large. So we're going to do some level setting here. And we're going to let you know where we're coming from. Ambulatory care nurses in the US have two main entities that provide standards and scopes for the care that they provide to their communities. Okay. The first is Triple ACN, which you are all familiar with. And then the second is the American Nurses Association, which you all should be familiar with. Okay. As a reminder for those who are members, Triple ACN's mission is to shape care right where life happens for our patients and their communities. And we do these through strategic priorities and goals. Today, we are really focused on how we can influence healthcare policy through advocacy. So that's where we're going to spend our time in our space today. All right. So, as nurses, you may be thinking, do I really need to get involved in politics and policy? Okay. I just want to take care of my patients. And the answer is yes, but only to the degree that you are comfortable. Because unfortunately, policy, whether it's big P or little p, okay, impacts how we deliver care and how our patients and communities receive that care. As a reminder, the American Nurse Association delivers our code of ethics for our profession, and it calls all nurses to be committed to those we provide care to. It tells us that we must be an advocate to the recipients of that care. We have to advance the profession through standards, policy generation for nursing, health, social concerns, and promote social justice so that we can eliminate health equities. And we want to make sure that we are facilitating human flourishing. So, right now, Code of Ethics, Professional Nursing. I need you guys to look at this. If you don't know where to find it, I believe we have it in our resource at the end of the presentation. Know your code of ethics, know where you belong within the profession of nursing. And social justice, it is embedded in the core of what we do as nurses. From the beginning of time, it's always been about equity. It's always been about access. It's always been about returning the patient to the proper place where they're able to get back to their healthiest self, whatever that healthiest self looks like. So that's all we're doing here is level setting and giving you the oomph that you need in order to go forth and be the advocates and the activists that you need to be for your patients, community, and the profession. So just as an aside, we want to talk the difference between policy and politics. So policy is the rules, plans, procedures, is the written that kind of gives us instructions for how things are to happen. Um, it can be influenced by culture, politics, or even the economy, but they are very specific actions for very specific topics. Politics, on the other hand, is the interaction between stakeholders. So you and I, people, funders, advocates, activist groups, everybody who has a stake or claim in something. There's the interaction between those people and then their individual special interests, right? So it's this idea of power and influence, the give and the take, the tug and the go. And then it really is concerned with governing and decision making. Okay. Now, what makes this so very special is that policy and politics are often intertwined and they overlap and they influence one another. And it is really hard to disentangle the two. Like many of you said, in how you felt about being uneasy and, nervous and with the climate, a lot of the climate that we're feeling today directly impacts policy tomorrow. And then that impacts how we deliver care and then how patients receive that care and how sick or how well they're going to be. Okay. So it makes us think about, what does healthcare advocacy mean? What does that look like? So the National Association of Healthcare Advocacy, they believe that advocacy is the support for and promotion of quality healthcare for individuals, families, and larger communities. And there are different spectrums or levels to this advocacy and to how people need to be advocated for across the spectrum. So, individual to the system or policy level. And there's a lot of different ways that you can do that. When we think about nurses and advocacy, we often are thinking about that individual and or community level. Hardly ever is do we really talk about engaging and teach nurses how to be advocates at that system level and even how to influence policy. It's not necessarily embedded into our undergraduate nursing curriculum. If we go on to do graduate studies, it's always usually an elective that we have to choose. It's nothing that is set forth to teach us how to be actual advocates and to improve or to move the needle in healthcare. So we have some work to do as nurses. So if we have any academics on the line or people who are in charge of curriculum, or even people who manage clinical rotations. I think that that's something that we have to think about, is how do we make nursing bigger in this space? How do we give nursing a bigger voice? And if you're not following me, follow this. The American Medical Association has a huge lobbying arm. So if there is something that some bill or some law or something that politicians are recommending that they think will impact the physicians inside of their organization, they immediately put money to task and they send out their lobbyists so that the the interest and the request of their membership is well known to the people who are making laws. Okay. Physician voices are well heard. They are well heard. They even, a couple of years ago, they funded a study that looked at the care between physicians and nurse practitioners. And so because they were trying to prove that nurse practitioners gave less quality care than physicians did. So these are the kinds of things that our physician colleagues are doing in order to make sure that the voice of medicine is well heard. And these are not tasks and tools that we are utilizing or that they are well taught in nursing. And these are things that we need to do. ANA has a strong lobbying arm, but their voice is not as loud or as effective as our physician colleagues and even the hospital association. Okay, so I just want you to think about collectively what can we do as a profession, and then more individually as a nurse, what can you do? It's very important because the nurses have to see impact of policies directly on their patients and the communities that they serve. Nurses can transform empathy and experiences into words and actions. We're with the patients, we're boots on the ground, we know what it takes in order to make patients well. But we need to be able to articulate that effectively for the people who are um, making the law. So I did not have time, but one of my mentors at NYU posted on LinkedIn just the other day that she's involved with a lot of global healthcare, and there was a global study that was done that talked about the investment in nursing. So it was almost 3 times the investment of what you put into nursing and what you get out. So just investing in nursing, if you invested $1.3 trillion, then you got 3 point something trillion dollars as a return on investment. So that's a brand new study. I just read it before I got on here, so I don't have the ins and the outs. But those are the kinds of things that we need in order to show the worth and to put our experiences into words, evidence, and action. And then finally, we want to make sure that the responsibility and obligation to shape and direct policy. We are a part of that so that we can address social determinants of health because we see how social determinants of health impact our patients. So I want to take a minute and talk about some of the work that we have seen be very successful that nurses have led. And as I'm clicking through this, you're gonna say, "Oh yeah, I know that. Oh yeah, yeah, yeah. I signed a petition for that. Oh yeah, I remember this." Because I want to jazz you up to say, when we come together and say enough is enough and this is what we want, we're able to get things done. So, do you guys remember COVID-19? The pandemic, it just happened, right? So there we lost a lot of people, a lot of patients, a lot of people in our community, a lot of citizens, but we also lost a lot of healthcare workers, a lot of healthcare workers. My girlfriend works at NYP, and she was mentioning that it was so bad in New York at the time. They were like the epicenter by itself. And it was so bad that they were delivering care, and the nurse would be taking care of the patient, turn around to get something done, and turn back around, and the patient had expired. Can you imagine that level of stress and anxiety, and that level of volume of death, and then not knowing if you were going to take that home to your family and to your friends? And then the geography of New York City, it doesn't bode well for pandemics, right? Small spaces stacked on top of each other, close quarters. And so New York saw a lot of nurses and physicians, respiratory therapists who were impacted by COVID, who died, and also their family members. So one of the biggest issues is that we were not prepared. We should have been, but we were not. And we didn't have personal protective equipment, PPE, and we didn't have the resources, we didn't have the staff and all the things. So the National Nurses Union came collectively, they had lobbied and they have fought in order to get protection for nurses and healthcare providers for just basic PPE, right? So they can get a bill pass, get funding, and all the things. So nurses were behind this, standing up and saying, hey, wait a minute, thank you for the shout outs. Thank you for, because remember, people was holding up signs, calling us heroes as we were leaving the hospital and things like that. Thank you for all those things, but we are dying. And we need for our government and for our Congress to do something now in order for us not to have to reuse PPE and putting it in paper bags and going from room to room. So that was because of nurses. They came together and they said, enough is enough. Another example is the safe staffing, right? I want to highlight California. There are several states who have some form of safe staffing laws, but California is the only state with mandatory nurse to patient ratios across all units and specialties. Okay. Other states may have something just for the ICU, or they may have things around just staffing in general, but not specific patient to nurse ratios. So California decided that these nurses fought and fought and fought for this. And they were able, even with the mandatory breaks and things like that, if there is a California nurse on the line, please chime in and, tell the people how right or what I'm missing in my dialogue. But they put in the work, and because they were able to put in the work and they were able to go to the legislator, they were able to get this stuff passed. And they are the gold standard because no other state has done this. Now, New York has an ICU nurse to patient ratio that passed in 2021, but it's just the ICU. Massachusetts has one that passed in 2014, but it's just for the ICU. So we need more safe staffing laws in order to prevent these horrible errors that are happening, because it's really hard to take care of a lot of patients, especially with high acuity, and not be able to do all the things that you need to do. So this is just another example of how nurses' voices makes a difference. I see people are putting things in the chat. Just give me 1 minute and I'll get to that. Another thing that I would like to show is at the national level, there was a Mommy Bus Act that was introduced by Representative Lauren Underwood. And she is out of Illinois. She's a nurse. When she came to Congress, I think she was one of two, and then there was three, and I think now they're back to two. If I'm not, I think the other nurse was out of Texas. If I'm missing something, put it in the chat. So the Mommy Bus is just a collection of about 13 bills that were co-written by different members of Congress and their community correspondents. And it was basically to help, offset the Black maternal mortality rate in the US. Our numbers are likened to low-income countries, which is just not something that should happen with all of the money that we spend on healthcare, and all the things that we do with the high tech and all the things that we have, the best minds, all the things that we have going on for us in our healthcare system. So this was introduced in 2021, and then it was reintroduced in 2023. Now, what they did, individual states were able to do their own mommy bus. And I love this because the states have their states' rights. So they're able to do what they need to do for the state and for the constituents of their state, even if the US government does not do that. So California passed the mommy bus law in 2021 when this was not passed at the federal level. Michigan passed a law, and it focused heavily on research, data, and quality reporting so that we can keep track of what is happening in the state And then, research can help us dictate where we go next. One of the things that they put into place was money for scholarships for people to go through the doula programs. And we know through research that having a doula, a personalized individual person to help you navigate your pregnancy and birth, directly impacts outcomes. And then I really like Oregon because they include in their mommy bus, they included housing and doula services. And when we think about Maslow's hierarchy of needs, with the main needs at the bottom, having shelter and having safety and security, they're right there at the bottom. So we can't really dictate health outcomes without meeting the most basic needs, right? So we can't start introducing programs, but people are homeless or they have unstable housing. So I really love that Oregon was able to put that into their bill. And then finally, I live in Ohio. This kind of explains it to itself. The nurses are tired of getting beat up in the hospital. They say enough is enough. We need to pass a bill. And I looked earlier to see um, how many states actually have a law that is against violence in healthcare workers. And it's just like a couple of handfuls of states who do. Now, the emergency room nursing association, they were able to lobby, and again, these are nurses, they were able to lobby, and across the country and almost all of the states have some type of law against violence with emergency nurses. Okay, so these are all just examples of how nurses can use their voice to advocate for what we got going on. So let me take a moment. Can you talk about some of the reasons why nursing's lobbying voice isn't as loud? Ooh, funny discrepancies, membership. Okay, do you want my PC answer or do you want it's so many different reasons. Yes, membership. I think one, we don't teach it. We're not involved in it as much. Most of the nurses that I know that are involved, whether they ran for office, whether they work on campaigns, they work in policy institutions, is a few far in between. When we teach to the test, we are very practice oriented. We want you to graduate, take your NCLEX, and go work in an inpatient setting, right? So everything that we talk about is to that. You start to get advanced degrees, and then we start to talk more about, oh, we need you now to teach and to be an academic, but we don't really expand our horizons beyond clinical in academia, right? We don't talk a lot about working in government and working in industry and policy. So I think that's one issue is that we have really boxed in our options, and nurses don't know what options are available to them until they see it. The second thing is we are a female dominated profession. I don't think I need to say anything more about that, right? Because we kind of see that playing out with the patriarchy, where women's voice is just not as loud and as effective as men. Um, so I think that's a part of it. And then membership is low. Like when we think about it, we have what about 4 million licensed nurses in the United States? And when you go to your individual um, professional associations, the membership might be like 2,000, 3,000 here. Even though 10% of the 4 million work in ambulatory care, you don't see 400,000 members of AAACN. Okay, so membership is low, engagement is low. When I worked full time at the bedside, the consensus was let me clock in, do my job, clock out, and go home. I don't want to sit on no committees. I don't want to be a part of no councils. I don't want to do nothing extra, especially if these nurses were working night shift. So the professional development just wasn't there. Keeping up with skills and keeping up with knowledge was there, but being actively engaged outside of work, it just wasn't there. Now, you guys can put in the chat what you see in ambulatory care as far as professional development. When I was the director of nursing, I had professional development built in. So every month, I had my nurses do something under professional development, where whether we went somewhere, we brought someone in. I had the dollars, and that's what we spent it on. So you guys can, chat it up in the comments, but I think that those are the main reasons. Okay, so let's talk about some commonly used terms so that we're all on the same page. So everybody has seen this graphic somewhere. Well, I will say everybody, but most of you have probably seen this somewhere along the line, and the difference between health, equity, and equality. So on the left, you have equality, where every single person has the very same thing. Now we want to see the game, right? And so we're going to give everybody a box because we want to make it fair. Nobody needs to get anything extra. Is this is based on merit, or this is based on, everybody just you get a car, you get a car. Everybody get a car, but everybody's getting a Prius, regardless of how big you are, how large your family is. Everybody's gonna get a Prius, and you just gonna have to make it work the best way you make it work. And then this is what you get. The adult didn't even need a box, right? The baby, even with a box, still doesn't get what they need to get, right? And then on the right side is health equity, where, oh, I see that you, adult, may not need anything. Maybe I just need to walk you up to the fence, but I see that your children may need more. Maybe this child, because they already have typical behavior and typical development, mental things going on, where they might just need an extra leg up. But then you have this other child who doesn't have any of those things, right? And they need a little extra care more than the other child. So then we give them two boxes, or we give them as many boxes as they need to be successful and to reach their goal. So that's the difference between equality and equity. It's that thing where life isn't fair, right? Get over it. But how do we as nurses make healthcare fair and not tell our patients to just get over it? So, example is that this insulin costs $400 a month, right? So, what we're saying is, look, this is the cost, figure it out. So the person who has a job with benefits and they got two incomes, they're like, okay, great, I'll pay the $400. But then you have this other person who have unstable housing, they don't have insurance, they work a job on contract, and they make minimum wage. Do we just tell them to get over it? That's just how the system is, or do we try to give them extra to help them out so that they're able to meet their needs? So that's the difference between equality and equity. So then we're thinking about this idea of social determinants of health. These are all of those non-medical factors that influence health outcomes. So I like to tell people, this is what I think when I think about these types of things. There are factors that sometimes are beyond our control that directly impacts how well I can manage my health. Living in a food desert. If I live in a community, let's say, I'll give you a good example. Where I live right now, when we first moved here 18 years ago, we had a lot of young families. We had a well-maintained park with baseball fields, soccer fields, all the things. And then as my children got older and the neighborhood children got older, there was less care. And I remember going to the baseball field with my kids and sitting there watching baseball and watching soccer. And then as they got older, I saw that same field getting, overgrown and nobody taking care of them. So then the generation after them did not benefit from what my children had. Okay. In my neighborhood, two grocery stores closed. I have a car, so I can drive a little bit further. But what about those people who can't drive further? How are they supposed to get their groceries? Even though there is a McDonald's on each side of my neighborhood where you can get a dollar fry and a dollar burger, but you can't go to the grocery store to get. Okay. So we really need to start thinking about how these social needs and these things that are happening in the environment around our patients are impacting their ability to take care of themselves. So we have to start looking more upstream. Like these downstream things are just like, what can I do to help provide your care? And I didn't add this graphic, but there's in the research now, I think it's 90-10, where 90% of social needs impact care, and 10% of what we actually do to the patient impacts care. And because we work and live in an ambulatory space, this is really true for us. In the inpatient space, we can knit you up real nice and we tell you what to do and when to do it, and we heal you, and then we send you back to these low resource communities, and then you end up right back into the hospital, right? So we really need to go upstream and start thinking about policies and um, um, thinking about community organizations and how things are funded and how things are are labeled. So like in my neighborhood, you have to go through city council in order to get a license to open a market or a store or something like that. So there are ways to partner with community organizations to say, hey, we need to give more zoning acumen for more stores to come in, healthy stores. Like there can't be another fast food restaurant in this 3 mile radius. It has to be somebody who's going to provide and sell fresh produce and things like that. So those are just ways that you can do that. Okay, so we're going to talk about health disparity and health inequity. So health disparity are these disproportionate health outcomes, negative health outcomes that is based on group characteristics. So it can be like based on race or ethnicity or socioeconomic class or things like that. And it's usually tied to socioeconomic issues or tied to like where you live, how much money you make, what your educational level is, things like that. And the one before you is really about HIV. So African Americans make up about 13% of the US population, but they represent almost half of all new HIV cases. So that's a disparity to think like, okay, what is happening in this community? And then if you drill down further, it really is in certain geographical regions of the country as well. So we have to start thinking about what is causing, what underlying causes are influencing what we're seeing in these numbers. Now, health inequity is the same differences in health outcomes with the groups, but now we're adding in injustices and unfair practices. So these things are systemic. These things are happening because somebody they actually created systems and practices that caused these things to happen. So it could be the location of drugstores and reputable um, um, places to buy condoms, right? It could be, oh, here's a big one because this is something that is real and that's happening. Sex education in school. Who has access to effective sex education? Okay. So those things are systemic and they are created. They happen because somebody put some system in place to make sure that a certain group of people didn't have access to certain services, resources, and education. Okay. So, thinking about this whole HIV thing, where we saw overall, like we had that spike when it first came out, HIV and AIDS in the 80s. And there's been a lot of research going on, right? And we've done good work with getting the overall transmission rate down and getting education. And the more you know, and do you know your numbers? And we had all types of campaigns and all that thing. But now, in the last decade, you have a certain demographic that is having increased HIV infections. So using Slido, I want you to tell me what are some systemic challenges that may be exacerbating this health outcome? Costs. Oh yeah, that's a big one. Costs for medications. So I have a colleague who I think he's in Philly. He's a physician. His research looks at African American males and why they don't take, who have HIV. They're positive for HIV and they don't take their prescribed treatment because we know that if it's undetectable, that is untransmissible, but they're not keeping up with their treatments. And cost was definitely a big one. It's still stigmatized. So we got some work to do. Like where are these messages coming from that is causing stigmatization? Access is big. Access is big, and we're going to talk a little bit more about access here in a moment. Mistrust, yep, medical mistrust. That's a given. I don't even think we need to talk about that. Decreased research with current administration. Oh my goodness. And you're going to see more education. Yep. Misinformation is big. It's big. Yes. Racism. Yep. 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 All the things. Yep. 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 All the things. Okay. Very good. Thank you guys. Let's move on. So, we're gonna skip this. This is maternal deaths. Before you see Black women die, right? They're 3 or 4 times more likely to die from being pregnant in childbirth than their counterparts. And in this case, with maternal deaths with Black women, several studies have found that even Black women with high levels of education, high levels of income, and regardless of what age group that they're in, they still have a higher rate of mortality. So they can be college educated, have a good job, um, make good money. They can be well into their 30s and 40s, and they still have a higher rate of mortality. And the following causes have been linked to deaths: implicit bias, okay, not microaggressions, not listening to Black women about their bodies and about how they feel and responding to their concerns. Even Serena Williams had a pulmonary embolism in when she was delivering her first child, and she almost died. And she said would not. She kept telling them, "I'm having pain in my chest," and they kept telling her, "Oh, it's all right. You're good. No, you're fine. You're breathing fine. You know your oxygen." And she said, "No, no, no. I'm telling you, there is something wrong with me." And come to find out, she had a PE. And she is an athlete, right? She makes millions of dollars, right? In her 30s, okay? And she's not alone in that. Systemic racism, we already talked about that. Underlying health condition, things that have gone unnoticed, undetected, undiagnosed, and untreated. And then those social determinants of health. Okay, so race and place matters. This is from my own work looking at community health centers and colorectal cancer screenings. The darker the blue, the higher the rates for colorectal cancer screening. And then, as you can see, the states in the Southwest have the lowest colorectal cancer screening rates of the country. Okay, and then Wyoming, for some reason, they're not doing too well either. When we look to see, hold on, when we look to see where most African Americans live in this country in the last decade, we can see that the majority of them are in the South, right? And then it's the darker the green, the more Black people. And then, you got some out West, but the majority of them live in the South and what we call the Deep South, okay? Then when you look at where Hispanics live, you can see that the majority of them live in the South and West. Okay. Okay. And that's also following a pattern where we're the lowest colorectal cancer screening rates is. And then when you look at this Medicaid expansion, you can see that the people in the light blue, they have not expanded Medicaid as of 2023. And really it's 2024 now with the latest data. And you can see it's in the South and in that lone Wyoming up there doing what they do. And you can see it directly mimics what's happening with those colorectal cancer screening rates. So race and place matters, okay? These are not only health disparities, these are health inequities because the system is set up where certain groups of people are not going to receive what they need in order to actuate their health. Okay, there's a chat. Rite Aid is closing. Yep. I will have to go to another town. Yep, a whole nother town. Yep. And you have a car or you have some way to get there. What about the people who don't have access? What about our elders? What about people who are disabled? So, yep, you have a car. So I think that these are things that you have to be able to identify as systemic and strategic health inequities. I haven't even talked about rural health, right? We're going to talk about that, but I haven't even touched on it. Rural health, just as a whole, regardless of who lives in these towns and in these rural communities, the system is not made in order for these people to have access to care. Lower income, and it's the big, yeah, transportation is a huge thing. So quote came from this quote came from a nurse in 2020, and they're saying that in order for you to make it as a nurse, you have to be aware of social injustices and the systemic racism that exists, and you got to be ready to challenge them and change them. Okay. So here are some health equity frameworks. I'm not going to go through all of them before the thing of time, but I do want to talk about this one because I think that you're able to use this in your everyday work so that you can map out your programs and what you're doing to see if you're actually integrating social care into what you're providing to your patients in the community. So this, you can find this, it's the report, it's called Integrating Social Care into Delivery of Healthcare. And it was from the National Academies, okay? So they identify 5 activities that we can focus our nursing interventions to streamline the social needs with healthcare that we provide. The first one is awareness. If you map out the nursing process on this, you're going to see where it makes sense. The first thing is awareness. So we are assessing and identifying social needs of our patients in our communities. Adjustment, this is really about making accommodations. So you can't be a stickler about the care and the service lines that you provide. That's equality, right? We offer these hours and this mode to everybody. Pick one, regardless. It needs to be about equity. So if you can't come in, can we offer you a televisit? Even though we don't typically offer televisits on Wednesday, can we do that because we understand that you have a transportation issue? Can we open a service line where we offer nurses to come into the home and do your assessment instead of you coming into the office? Okay. Can we provide pharmacy at the time of your appointment so that you can do everything in one loop? The next thing is adjustment, where we're really talking about it's assistance, connecting patients to real community care and resources, and not just like handing them a paper and thinking like, oh, I thought that community center was still open, or I didn't realize that that food bank was no longer there. Like, we are really providing real-time effective assistance to our patients. Alignment, connecting and collaborating with community safety net resources so that these patients are well provided for in the community in which they receive care and where they live. And then the last part is advocacy. We want to make sure that we are promoting policies that facilitate health equity. Okay. So we're going to skip through this. So this is how policy changes really make a difference in healthcare. You guys saw this. If you work in peds, and even if you work in adults, you know that they have that even more recently than this, he fired and got rid of everybody who sat on the vaccine committee. Okay. So there is a vaccine council that meets, usually I think they met twice a year to talk about vaccines, especially the flu, because the flu, they use whatever strains were more prevalent. So it changes a lot year to year. So they can talk about what needed to be in the flu vaccine and how they were going to recommend it. All those people were fired. We are absolutely on our own. Okay. We're absolutely on our own. And flu season is around the corner. They've already changed the recommendations for COVID vaccines. So it is no longer recommended for anybody who's not a senior citizen. So that directly impacts the kind of care you're going to give to your patients and then also how they present to you when they come to your facility. Medicaid cuts is another big one. One in 4 in 10 births are covered under Medicaid. So if we're cutting Medicaid, how are people going to manage their prenatal care and their aftercare, their postnatal care? And I just told you about the disparities in our maternity mortality rates. So how is this going to impact it even more? And then we all know about this bill with the DEI. And these are some ways that reversing DEI have on healthcare. So funding cuts, which somebody added at the first slide. It diminishes gender affirming care. It cuts funding to healthcare education for underrepresented groups. If I don't know if you realize this, but the government funds healthcare education. That's government funded. So when they started gutting different programs, so for example, there are funding to like rural areas, underrepresented areas, all of that's DEI, and all of that has been cut. Loss of culturally responsive care. And then, of course, people don't know what to say and what to think and what to do. Everybody is afraid. Okay. So that's how that does. So we are going to take a quick quiz. So join the next slide I click, you're going to have 15 seconds to read and to answer. Okay, so join the quiz. I see y'all. Join the quiz. And then we're going to. All right, I'm going to click. Here's the first question. Okay, very good. You guys did well. It was social determinants of health, those non-medical factors, okay? Next question. Okay, very good. So remember, everybody is given the same thing. That's health equality. That was the right one. Oh, I'm sorry. The last one was health equity. This one is health equality. Yep. Health disparities. Very good. Very good. Health inequity. Okay. Up the leaderboard. Okay, Beth. Very good. So the hardest one, because I think I messed up that question. So that's okay. All right. Very good. So I want you guys to get active. Um, I want you to, if you're not already a part of more than one nursing association or organization in general, I want you to join an organization, get your membership up, and spread the wealth. And then look in to see if your organization will pay you back for membership fees. Okay. I want you to, within your own organization, I want you to be a part of shared governance. I want you to be an advocate for not only your patients, but for the nursing profession. So looking at policies and procedures and workflows and saying, hey, this doesn't work, there's a better way, and how we want to align with that health equity framework to make sure that we are fluid and flexible enough to meet the needs of our patient. I want you guys to sit on committees and boards. Find a board, any board, where you can use your nursing expertise and so that you can be an advocate for healthcare. Okay. Because remember, we can be advocates, individual, community, organizational, systemic, and through policy levels. Okay. Contact your representative. So there's this 5 calls app that you can use, and it also is a website. You just look up 5 calls, and it gives you scripts. It gives you one click where you can, all you gotta do is like put in your zip code, and you talk about, you click what is of importance to you, and then it shoots off communication to your representative. Run for office, y'all. Okay, run for office. 2 areas that we can be thinking about is rural areas. We didn't talk about that. There's a lot of rural hospital closings due to reimbursement being at all-time low. And then also when we're thinking about Medicaid cuts, 1 in 5 people that are losing Medicaid are being cared for in the community health centers, which are already under-resourced. Okay. So if you have pressing advocacy concerns, call your representative and tell them there is still time. Do not vote for this bill because it's going to gut Medicaid. And then, as my fearless mentor said, fear only works on people who are afraid. So don't be afraid, and don't let people make you think that you don't have a voice, because the only thing to fear is fear itself. Now, how do you guys plan on getting involved? If you have questions, you can feel free to put them in the chat or unmute yourself and ask your question. I love that y'all are typing about how y'all gonna get involved. I love to see how y'all gonna get involved. Speak up. Yes, thank you. Speak up. Please speak up. Don't let anybody steal your voice in any way, shape, form, or fashion. Make sure that you're speaking up. Use your voice. Bring topics forward surrounding these topics in our shared government. Yes, please bring them forward. And then bring the evidence. Like, don't just bring up what you feel about it. Bring, like, this is what's happening in our community. This is what's happening in our state. This is how it impacts us directly. And get nurses energized so that they are able to do the work, and that we can listen. If you want to go far, go together. You want to go fast? Go alone. So get a group of people and get at it. I think people stop typing, so I'm gonna. Oh yeah, I'm a member of New Jersey Nursing Association, ANA. I participate in shared governance, research facts, discussion with others, peace, primary care. She calling everybody. Listen, reinstating vaccine guidelines. Thank you. Testify. Nurse Day at the Capitol. Yes, please do that. 5 calls. Speak up. Just join. Okay. Active member of a nursing organization. Staying informed. Locals group. Joining committee at my job. I love it. All of the things. All the things. So you guys, this is where you can find our list of resources. Please make sure you scan it. And then, Leandra, can you put that link in there one more time in case they don't have the, thank you. Thank you. Thank you. This is how you can reach us. You can take a picture of it. I'll put my email in the chat. This is Leandra. And then that's it for us. That's it. So we're right at time. Thank you. Thank you. Thank you. Thank you. Thank you, everybody. We made it an hour.